Hello, I'm Dr. John Kruse, and today I'm going to be talking about, does one grand psychopathology factor, the P factor, explain all mental health conditions? As usual, I'll be talking for about 25 minutes. This video may wind up being longer than that if there's many questions at the end, and I'm open to questions on this or other topics. And as usual, I will start with the take-home message and go from there. So the take-home message is that there are a few hundred different diagnoses right now in the DSM-5, our Diagnostic and Statistical Manual for Mental Health Disorders. The assumption there is that these are each distinct, separable entities. So ADHD is different than depression. It's different from schizophrenia or OCD. But we see that there is huge comorbidity. If you have one condition, you're likely to have another. There's a huge overlap in symptomatology. There's changes in how people present over time, and the attempts to find specific causes or biomarkers for what makes people develop schizophrenia instead of bipolar disorder, instead of ADHD, have not been very productive so far. So starting decades ago, there were attempts, particularly in child psychopathology, to, rather than looking at specific conditions, to posit that there were two generalized factors, an internalizing factor and an externalizing factor. I'll say more later what those are, and maybe even adding in a thought disorder category. This explains some of the variability and messiness we find, but in 2012, one research paper found that adding in a P factor, so a global psychopathology factor in combination with some other major factors, was a better fit for explaining the data, and they likened this to a generalized factor for intelligence. So some of the intelligence research, and there's been pushback against this, finds that in addition to specific mathematical and verbal, spatial abilities, that there is a general intelligence factor, and that explains a large part of the variation in performance on intelligence tests and in daily life that we see. So akin to this, there is a claim that there's a general psychopathology factor, and there have been hundreds of papers finding some evidence for this since then, but the criticism has been that these definitions are very vague. What is actually this P factor? What does it entail? Is it really basically a thought disorder? Is it neuroticism? Is it emotional dysregulation? I'll get into all that. And there's been pushback that this is really a statistical model and not necessarily a reflection of the structure, underlying structure, connectedness or lack of connectedness of mental health conditions or problems. So the big value so far is that it's pushing us to think more in terms of comorbidity rather than putting each thing in a tiny little box, thinking about transdiagnostic categories in terms of treatments, either medications or talking therapies, and looking at how we include people in studies, and rather than, again, trying to simplify and purify for someone who only has ADHD without depression or without something other condition, and looking at the whole picture of what's really there in life. So that's the end of the take-home message, and jumping right into it. So as of the most recent version of DSM-5, the Diagnostic and Statistical Manual 5, and there's some letter after it too, there are now 298 different disorders that are described. Again, the assumption is that these are all distinct, separable entities, and a criteria for many of them is that this is not explained by another condition. So those are rule outs. And as I mentioned in the take-home, that there were attempts to look at the picture of diagnostic clarity in a different way of looking at general big factors rather than dividing everyone up into whatever little diagnostic label boxes we had. So in 2012, Benjamin Leahy and collaborators at the University of Chicago were analyzing data from the National Epidemiologic Study of Alcohol and Related Conditions. So this is a nationwide US study, enrolled more than 40,000 people, where they statistically try to get a representative sampling. They actually oversample certain populations and do an extensive psychological interview evaluation to assess for 11 different common major mental health conditions. And then these individuals were actually retested 3 years later. Not all of them were recaptured again, but more than 35,000 were on the second. And when they crunched the data, they made a predictor trying to use a three-factor model. And here they were using three factors were an externalizing disorder. So internalizing, when you break it into internalizing and externalizing, internalized tend to be inward-looking depression, anxiety, symptomatology. Externalizing tend to be outward, acting out behavior, sort of ADHD, substance abuse disorders, conduct disorders, antisocial personality disorder. For this, they were using three different factors. They used an externalizing factor, and then broke internalizing into a fears factor and a distress factor. And that covered some of it explained a lot of the variability in diagnoses they were seeing in different people at different times. But when they added in a general factor, it fit the data substantially better. So it was a general factor not replacing, but in augmenting these other factors. And they raised the possibility that there was some general psychopathology factor P, it's labeled, that may explain away many of the problems we're having in dividing psychiatric conditions into separable conditions. So again, since then, there have been several hundred studies, and one of the most prominent pairs of researchers have been Terry Moffat and Avshalom Crespi, both now are at Duke, and in 2014, they published a study. This was a study based on the Dunedin, New Zealand set of data, and in the Dunedin study, it's a longitudinal study over time. They looked at everyone born in this small town in New Zealand, and in the year 1972, I think it's March of 72 to April of 73 or the other way around. So they have data on almost everyone who's born in this interval. They started studying these people at age 3, and they've continued on to age 38 at the time of the 2014 study. It continues to this day. And every few years, they did extensive mental health evaluations, as well as looking at other factors and testing. Again, there's originally more than 1,000 subjects. They have been able to retain most of those. It is largely a white, middle-class New Zealand study, so that's one potential restrictive value. But in their analysis of looking at mental health factors, again, they used a 2 or 3 factor model, and it was only when they added on a P factor, a general psychopathology model, in conjunction with the 2 or 3 factors that produced the best fit for explaining the data. They did comment in their paper that there was still correlation extensive between external and internal factors, which the very purpose of designating those is to get at different elements of psychopathology. And if there's considerable overlap, then there's some failure to do that. They also observed, as others have, that there's a strong gender bias, that internalizing tends to correlate strongly with women and externalizing with males. It's not exclusive, though, but there's clearly a gender aspect there. And they felt that their overall psychopathology factor actually mapped very strongly into, rather than externalizing or internalizing, this disordered thought content, which many of the earlier studies, particularly with children, one is that full-blown psychiatric or psychotic disorders are less common in children. So schizophrenia doesn't tend to peak till late adolescence, early young adulthood. And it's just harder to assess thinking in children because they have more limited vocabulary, more limited experience, more limited ability to explain what they're feeling. This Dunedin study also found that their general P factor was strongly correlated with certain personality traits. Personality traits have been studied at length, and the picture of high neuroticism, and neuroticism means, this is my distillation, excessive worrying, lack of feeling calm, soothed, equanimity. So it's someone who's fretting, someone who's always agitated by even small perturbations. So high neuroticism, low agreeableness, so don't get along with people very well, low conscientiousness, all mapped pretty strongly onto this general P factor. They also found that this P factor, this general psychopathology factor, correlated with retinal vasculature problems or abnormalities. So the retina you can examine easily, and the retina developmentally share an origin with blood vessels in the brain. So they're looking at retinal vasculature as a proxy for looking into the brain vasculature. And again, so there's some correlation there with potential brain abnormalities and this general psychopathology factor. And in their study, they didn't just limit it to this data set. They discussed what had been going on in psychonosology or categorization of mental health disorders over the last few decades. And they pointed out that most of the works has been focused on cross-sectional, looking at psychopathology at a specific point in time. And we need to look much more at longitudinal data like the Dunedin study, because looking at someone who just has depression now blurs people who are only having one episode of depression, like a postpartum depression, versus people who are chronically depressed all the time or recurrently depressed. And those may all be exactly the same thing, or they may be substantially different things. They also brought up that the issue of sequential comorbidity, that often we just lump, ADHD, it's associated. Lots of people with ADHD have OCD, have depression, have anxiety, have autism spectrum disorders. But there's, in some of these things, a specific sequence or comorbidity. So for example, ADHD often leads to anxiety, but anxiety doesn't tend to lead to ADHD. Now, anxiety, and I will talk on this, anxiety can show up or exacerbate ADHD symptoms, but in terms of full-blown anxiety disorder, there's one of these two sequences is far more common or likely than the other, and that's being missed in most of the research. Third big point they brought up is that, again, much of the earlier research looked at just these internal versus externalizing factors and sort of ignored psychosis as something weird or different. We don't know how to put it into the model, but they pointed out that psychosis is more common than it previously been thought, and more common in two different ways. One is that more people who are completely normal acknowledge having mild or even full-blown but brief hallucinatory or psychotic-like symptoms. And two, that psychotic-like or severe disordered thinking is present not just in schizophrenia, but it's present in depression. Everyone hates me, I might as well die. OCD, and lots of the thoughts there are clearly illogical, not reality-based thinking. Anxiety disorders, so that psychosis or disordered thinking specifically may be more prevalent and maybe a better, should be more explored more thoroughly as a pervasive factor or the extreme end of mental health conditions. So they also noted that psychosis was linked with the very high rates of comorbidity, and it was also linked with being very impairing. They also brought up the increasing numbers of genetic studies, so that most of the genetic risk is a general. So when we look at polygenetic risk scores for ADHD or for autism or for depression or for schizophrenia, there clearly are genetic components to all these conditions, but by and large, much of the genetic loading is for having any condition not specific. So it's not a completely separate set of genes that lead to ADHD and a completely different set of other genes that are leading to depression. It's tiny aberrations or in hundreds, if not thousands of genes that are leading to having any one of these different conditions. Two other points they brought up is that increasingly, rather than putting depression, ADHD, and schizophrenia into a categorical box, you either have it or you don't, there's an acknowledgement many of these conditions clearly exist on a spectrum. So with ADHD, the spectrum is defined for adults. You have to have at least 5 of these symptoms, but if you have 4 ADHD symptoms that are really severe and profound, you still don't have ADHD. And if you have 6 symptoms that are mild or just barely strong enough to register as a symptom, you're still diagnosed. So we have a cutoff that in many places is clearly arbitrary and, again, shows that there is an underlying spectrum. In some cases, like ADHD, the spectrum clearly goes from normal to full-blown ADHD. Whether it extends fully to normal in other conditions is less clear, but we're missing a spectrum dimensional aspect by lumping everything as a category. And they also drew a direct comparison between the general psychopathology factor, which was starting to be called P, with the general intelligence factor, G, for cognitive abilities. Now, they sort of posed that there was general acceptance of this G, general intelligence factor. And although, again, many studies do support it, there's been considerable pushback against the G factor as to either statistical or cultural artifactual. So they also raised the possibility in this 2014 paper, although clearly in subsequent works, they don't think this is likely. They brought up the possibility. Is P just a statistical construct? Is this just some factor we're finding because of how we're studying it and crunching the numbers rather than representing an actual underlying common cause or origin or process for developing psychopathology? So they raised that as a possibility. They also raised the possibility that much of the P factor could be explained by a network analysis. So rather than one underlying process or cause leading to all these psychopathological conditions, that maybe if you just had one condition like schizophrenia, the very nature of schizophrenia may make you susceptible to having depression or anxiety or OCD, or conversely, having one of these other conditions on a network level. So it may be that one thing is directly causing another, not that there's some big underlying cause causing all of that. They also brought up whether P is just an issue of response style, that it reflects how data was collected, and they felt that this was unlikely because the same P factor was already showing up by then in studies done using observer reports rather than just the personal response, and that the P factor did correlate or predict real-world outcomes like suicide and financial success in life. So if it was just a response style, it would be unlikely to have these real-world outcomes. And they also conceded that P might just reflect a common unitary outcome of dysfunction, meaning that this is just measuring sort of the severity or how mental health conditions fall out, and maybe representing bigger P factor just means you're more seriously mentally troubled. They also brought up, what is the essence or what is the body of this P factor, and that their data could support any number of different constructs. One is it could be just largely neuroticism. Again, that excessive feeling unwell, worrying that something's wrong and you have to do something about it, rather than the Zen-like calmness with life. There's some evidence that their P factor was a marker for poor self-control and emotional regulation. There was also a interpretation that their P factor was a marker of cognitive dysfunction and problems with attentional concentration, emotional control. And the fourth possibility, that their P factor actually mapped more strongly onto disordered form and thought. So again, not just psychosis, but the extremes of many different severe depression, severe OCD. And they felt that this P factor was actually meshed well with what's called the stress diathesis model, which suggests that there's some people, for genetic or other biological reasons, are particularly sensitive to stress, particularly early childhood stress, that experiencing that stress, number two, results in neural changes. Now, these might be initially protective, helpful responses, but over time, those are leading to pushing people into certain types of responses, which generate more stress, so that these people's brains become wired so that they're more likely to engage in patterns of behavior that get them into trouble again. And that over time, this results in sensitization to trauma. They are more vulnerable to the next trauma. And they concluded with that it was important to develop measures, scales to measure this P factor, because they were observing that, again, there's all these different possibilities as to what P may entail. We need to start looking at what it is, if it's a thing or set of things. And they also strongly objected to assuming specificity. So much of psychiatric research is siloed into looking at depression and looking at ADHD and trying to find blood markers or brain imaging that correlates with this. And even if you find a correlation, if you haven't tested it in other entities, you don't know whether this may be more emblematic of a general P factor or whether it's really specific to your condition. And they extended this even to treatments, medications, and therapies. We can show that certain forms of CBT are effective for ADHD, but CBT is actually effective for a broad range of conditions. Maybe we should be broadening the use of most of our medications and therapies. So one or two articles of hundreds looking at, again, and finding evidence for P factors have looked at ADHD, and what they found is that when you look at groups of people with ADHD and look at the polygenic risk scores, again, that's looking at the whole genome, all the DNA, in one group of people, looking at what's linked with ADHD and seeing if that really does predict who has ADHD in a separate sample. They found that a considerable portion of genetic variability with ADHD was captured by a nonspecific P factor, general psychopathology factor, but that for ADHD, there's also some genetic component that represents hyperactivity and impulsivity that's adding to this P factor, which is sort of what you'd actually like if a P factor is real and exists and present in all psychopathology, but there's also separate other factors making each, or at least some of our other conditions, distinct and really that other condition. At least that study did not find a significant association between the ADHD polygenic risk score and specific inattention after accounting for the P factor. So in their study, inattention was more completely subsumed in the P factor. And there have been studies looking at executive functioning in the P factor. We often, in the last few years, have been thinking of ADHD as an executive function disorder, but this study pointed out that executive functioning is impaired in a lot of conditions like ADHD, autism spectrum disorders, internalizing disorders in general, and that the idea of a generalized P factor may help sort out which, are there executive function problems that are across the board present, and are some just specific to specific conditions. So in general, while much of the literature has been supporting the presence of this P factor, there have been notable critics of this. And earlier this year, 2024, Ashley Watts, and her colleagues, she's currently at Vanderbilt, provided a critique of this P theory. And they found sort of 5 major factors of why they think this is being overused and misinterpreted. So the first, and I'd say the biggest argument, is that this type of bifactor model, so that there's one overarching or underlying P factor, psychopathology factor, and these 2 or 3 other factors, internalizing, externalizing, and other or not, that the very type and structure of that model is one that tends to fit any data set very well. And if we're using how well this model fits the data set, with meaning that this means it's a valid interpretation of the data set, or that the P factor is real, that's not a valid conclusion, and you can't keep using how well the model fits to substantiate that this is something real, because again, in lots of very different situations, this is much more likely to fit the data than other simpler models. So that's, from my reading, their biggest point. Second point they made is that the theories as to what is entailed in this P factor are very vague, underspecified, and that impairs the ability to validate or to test or falsify them. So again, is this P factor largely a reflection of thought disorder? Is it really a reflection of neuroticism? Is it a reflection of something else? Three, that this P factor poorly replicates how well it loads onto different conditions like ADHD, depression, schizophrenia. So if you look at how well this P factor in different studies, and I don't know whether they're cherry picking the data or not, but they looked at dozens of studies and found factor loadings ranging from anywhere from about 0.1 to 0.9 for how well the P factor loaded onto ADHD or loaded onto depression or loaded onto schizophrenia. That's such a broad range of loadings for what it should be an important revealing factor that it's essentially meaningless. Again, it might be that some of these studies were poorly done or done differently in ways that could be explained, but on the surface, having such broad loading factors it makes it look kind of meaningless. They also pointed out in their study, in their evaluation, that the assumptions of the bifactor model assume that there are latent variables, that there are underlying variables that are contributing to this P factor, and that many of the assumptions you need to make valid assumptions are not really applicable. So the randomness of these factors isn't known, and again, how strongly these factors load onto the general P factor, the general psychopathology factor, should be pretty consistent. If P is a thing, then how much anxiety is associated should be pretty, how much is anxiety a component of the P factor should be pretty consistent across very different studies. And they showed that a number of different latent variables that are thought to be factors and components of this general P factor, again, range from anywhere from 0.9 to 0.1, pretty much across the board in terms of how strongly they load onto the P factor. So their overall sort of gestalt complaint was that this P factor is reifying, and reification is essentially, because we have a name for it, we can call it a thing and understand it that way, that makes it a real thing. My best example of this, I'm not a big fan of economics, is the economy. We call something the economy, but it's not a real thing. It's a collection of different forces, factors, and we talk about it, we refer to it that way, and our very talking about it makes it more real and more thing-like. So their complaint was that the P factor for psychopathology is often cast as a latent, so underlying causative entity, and Watt and her colleagues, Watts, felt that the evidence actually was much more supportive that this P factor is actually more representative of a summation of symptoms, or more a severity score of how many symptoms you have, or a measure of how impaired you are, and that particularly since DSM-5, to have a diagnostic category there, one of the criteria is that you are impaired, that's part of the bias towards how this P construct is being generated. So I'm not a good enough statistician to know who's right or wrong yet. I'd say both sides are going to keep continuing data, and it's probably not an entirely right or entirely wrong argument. And I think the important messages to take home, other than the take-home message, is that we do need to do much more longitudinal work of looking at, is ADHD consistent over time? Is ADHD leading to dementia? Rather than just looking at cross-sectional, at the same point in time, someone has dementia and ADHD, or someone had depression and ADHD. And we also need to look much more at context in terms of personality styles, attachment styles, history of trauma, stress and adversity. And we need to move away from the silos. So many studies, if you're studying depression, you throw out anyone who's psychotic disorders, anyone who has ADHD, anyone who's suicidal. And the claim or the aim was to look at someone who purely just has depression and nothing else, but that doesn't reflect much of the real world and doesn't do a service to our patients. So that's all I'll say about this. Next week's topic is about fatigue and ADHD. And I see there are a bunch of questions, so I'll hop to. So Sir Austin said, I'm not used to seeing you this early in the day. Hello? Yep, so this is not my usual time. I am an early riser, so it was 8 a.m. in Hawaii, not a problem. I'm actually flying to Honolulu for some skin cancer treatment, so that's why I had to go early today. Pry USA, how can I treat mental health disorders without meds, please? Thank you. That's a really broad question. What I would say depends on which conditions, or maybe that's all one big P factor condition. Good sleep, I think, is one of the most important. I think it's more important than good eating. I mean, bad eating is an issue, but good sleep, enough physical. So what I tell people with ADHD, and this applies to almost everything, is take care of the 4 basics before you plan or structure other things in your life. Good sleep, good eating, good exercise, good relaxation, downtime, meditation time, fun time, recovery time, whatever you want to call it. Those are important for sustaining good mental health. And I'd say there's certainly a host of talking therapies, and as some of the research on this P factor, something like DBT, which is using a combination of mindfulness and cognitive behavioral therapy, seems to be helpful in many situations, and I should emphasize, can fundamentally change biology. We still often think of talking treatments are up here and only affecting our thinking, and medications down here affecting the body and the brain. But we know cognitive behavioral therapy, when it's effective for depression, anxiety, ADHD, changes brain circuitry, changes brain chemistry. So hello again, Q. Can I take psilocybin mushroom in microdose? Will it change my brain chemistry permanently? Will it have bad effects on my mental health? I'm already taking escitalopram, Lexapro, and atomoxetine Strattera. So I do have a talk on psilocybin. It was somewhat dated because it's probably a year and a half old now here. The things I would caution is that because it is still not regulated by governments or entities, how much you're getting in a microdose, you may not be consistent. We know that in the mushroom itself, so taking the same exact amount of the mushroom is also not going to stabilize or standardize your dose, that the mushrooms themselves can vary by a factor of 1,000 in terms of how much psilocybin, or actually psilocin is probably the major active ingredient. So if you're going to try it, get a reputable source and have your friend or enemy take half your dose every day first to make sure it's a consistent dose. I'm being flippant there. Will it change my brain chemistry permanently? So some of the evidence for particularly end of life or substance abuse, research on psilocybin, again, these are highly controlled research protocols, so it's highly selected subjects got into them, and highly regularized, and most of them weren't looking actually specifically at microdoses. So more than a microdose probably does have, at least in some people, profound psychological permanent changes. And I would say we'd have to argue at some level that's reflected in brain chemistry change, usually for the better. Psilocybin, particularly, not that it's completely free. So about a quarter of people do have a bad trip or some amount of panic. That's clearly the most common negative effect associated with it. Whether complete negative changes in personality and or flashbacks forever are associated with it. Those seem to be extremely rare for psilocybin, maybe more common with some of the other hallucinogens. Well, definitely more common with some of the others. So, hello, Dennis. Dennis says, Dr. Andy Barlow, functional neurologist, recommends everyone aged 35-year-olds and older get a neurologic exam to test for cognitive decline. Is that consistent with your clinical opinion? I'm going to give lots of, one is if he's mean, I guess what the question is, what is he recommending in terms of entailing a neurologic exam? So I've just gone through a neurologic exam at a memory clinic, at least the initial exam, and they did a version of the MOCA, the 30-point mental status change. They did some simple finger to nose testing. Can you stand on toes and walk? And even though this was actually a respected clinical center looking at memory issues, it was such a cursory and incomplete, I would say generally almost meaningless exam, and the person who administered it didn't stick rigorously to protocol. So I would say, so one thing, many people wait until they are late in life and are pretty convinced they're having substantial problems, and then they went and go and get a neurologic workup for cognitive decline. And for most people, unless they are really, really severely impaired at that point, the tests say, oh, this is where you're at. We don't know what your baseline is. So there is absolutely good and useful value to having baseline for pretty much everyone. How well you're going to get a well-done basic neurologic exam, I don't know. And given that memory clinics, at least in the San Francisco area, where I spent 30 years, the backlog, again, for people who have real potentially serious problems was 6 months or longer. It's telling people to flood the neurology clinics and get a thorough baseline. I don't think the system right now is set up to handle it or could handle it. And I'll go into one other, this is completely off topic, but it's one of my issues. So Donald Trump still brags of passing the MOCA exam, a standard cognitive assessment used to screen for dementia. And yet his quote after the test of, he could remember man, woman, child, camera, TV. I may have those quite off. And he repeated those, and clearly he indicated that those were the words he was asked to remember. Now, if he had a valid test, those absolutely would never have been the words, because they are very specifically supposed to be 5 random words, not words you're associating with each other, like those are clearly associated. So either he completely misremembered wrong immediately afterward what the words were. That's possible, but then that's showing some memory issue. Or the person who administers the test, which was Ronnie Jackson, who's now a Republican congressman, who has been cited by, he was an employee in the military and almost fired for drug abuse and other medical malpractice issues. If you don't have someone who knows what they're doing when they administer the test is meaningless. So enough on that. So Art 2 Productions, are you extremely anti-weed? So that is one of the extremely few subjects where I fundamentally changed my mind. So I do have a talk on ADHD and weed. So what I had seen for years clinically is that, particularly in the Bay Area before it was legal, many people were still using, and people were telling me, I'm sure it's helping my depression, I'm sure it's helping my anxieties, some for ADHD, more of those 2 other categories. And I had one exception in 30 years. When people stopped, to a person, with one exception, they all said, I was convinced it was helping my anxiety. I was convinced it was helping my depression. And now I feel more clear-headed, more positive, more able to deal with life, more energetic. So from that, I was moderately anti-weed, separate from whatever smoking or vaping may do to your lung or heart, but the limited, and it is quite limited, but there is some fairly well done data looking at ADHD and marijuana. And there you would again on the surface think, we can correlate marijuana use on a daily basis is coordinated with lower energy, less organized thinking, lower motivation. That on the surface is a horrible mix for ADHD, but there is evidence that there is some, at least subset of people with ADHD who do well with low dose marijuana. So, and I've seen some in my practice. So that's my marijuana answer. So Mr. AKA 1996 asks, why doesn't L-DOPA help ADHD even though it bypasses the rate-limiting enzyme in dopamine production? Also thoughts on generic versus brand for psychiatric drugs. For example, some say only brand Adderall helps them. So I am not aware of the formal studies on L-DOPA and whether it helps with ADHD or not. So unfortunately, I can't comment on it. I would have expected to find some effect, given that so many other drugs that help with DOPA, including Wellbutrin, not just the stimulants, but Wellbutrin, amantadine, and others do have some measurable effects with ADHD. So I can look into it, but I don't know the answer there. And again, it may be that they were just too small a study or not well conducted or some other reason that might really have an effect. The other topic is generic, and it's a topic I will be talking on at some point since it comes up often enough. Some of this is, I think, in one of my talks on ADHD. So the talks on generic versus brand name for psychiatric drugs. So I am, in general, a fan of generic drugs that if you can make the exact same product for a tenth of the price, and many companies manage to do that, then we should probably steer more business that direction. The question is, are they exactly the same thing? And interestingly, in psychiatry, so which I have the most experience, the two areas where generic drugs cause complaints as being different or inferior to brand name, and there's one other notable exception. So one is Wellbutrin has historically had lots of problems, less so in the last decade. I'll get to that in a minute. Benzodiazepines and stimulants are the two categories. So I don't sometimes hear it with SSRIs or tricyclics or buspirone or guanfacine or a host of other antipsychotics. There, much less often do I hear people complaining that are different results between brand name and generic. So one big difference between these classes of drugs, the benzodiazepines and the stimulants, generally we're dealing with direct effects. So the level of the drug in your blood is directly related to how much symptomatic relief you have. With these other drugs, they are, for simplicity's sake, indirect drugs. So SSRIs, most antidepressants, the level of the drug in your blood doesn't correlate with how well it's working for depression. They're working indirectly. They're starting biochemical processes going that take a long time to unfold. So I think it's interesting that, again, what I'm seeing correlates. So one of the factors, so with the generic drug, the FDA in this country says you absolutely have to have the exact same chemical structure as the treatment drug. And you have to be pretty similar in terms of how fast it's getting into your body, how well it's overall absorbed over time, but they allow some amount of stop, and it's in the 15% range of stop. That's enough for some people to either be reassured or not reassured that they're getting their effect, or for too much to go in too quickly to feel overwhelmed or overdosed or overdrugged or different substances. So that's, hopefully I'll, again, spend a whole talk on that, but that's where I'll leave it right now. So the most recent example is Vyvanse went generic in last fall, August, September. I had numerous patients who were switched over and were completely unaware that they were now taking a generic. I'm not actually clear how pharmacists could do that, because for other controlled substances, they absolutely have had to check with me, and I've had to rewrite prescriptions for switching between the two. And I have had one or two people who have had, switched over to the generic form of Vyvanse and did feel they detected a difference. So, but many didn't. So that's where I'll stop there. So Q is asking, can he take bupropion with atomoxetine to improve the efficacy of both the drugs? So I should, and I probably don't repeat it often enough, but I've not evaluated anyone who's writing in here. I don't know your medical history. I don't have a doctor-patient relationship, so I can't and shouldn't be making specific recommendations. So this is on the purpose of general information. What I can say is there are certainly people who are on the combination of bupropion and atomoxetine. They have some clear overlap in what they're doing, some clear differentiation in what they're doing. And in many cases, it allows people to take a lower dose of one than if they were only on that drug. And in some cases, it does improve the symptomatic relief they are achieving. And the big warning is also the potential for increasing side effects. And two that would come to the top of my mind is increased likelihood of hypertension, increased blood pressure, and increased likelihood of just sympathetic overdrive, too much anxiety, agitation. And Q also shares their experience with generics, that for atomoxetine, his experience was some generic brands worked and some didn't. And you're welcome, Art2 Productions, who's thanking me for what I do. So I think that's the end of the questions right now. Next week, I'll be back at the regular time, and I may wind up switching times to earlier in the day in the long run. So if you have feedback on what works for you, let me know. Next week's topic, again, is fatigue and ADHD, and stay healthy, stay happy, and thanks for all the questions. I'll be back next week.